Everyone, good afternoon. It is my great pleasure to welcome you to this EHMA webinar, Strategic Investments Leveraging EU Funding for the Digital Transformation of Hospital Settings. My name is Federica Margheri. I'm the Executive Director at the European Health Management Association, and I'm very pleased to be moderating this webinar today. With this webinar, we do want to explore the urgent need to digitalize medication management pathways in hospital settings across Europe. And we also want to outline some of the key EU funding programs that are available to support this transformation. I would also like to take the opportunity to thank Becton Dickinson, BD, who has supported EHMA in exploring this topic of the digitalization of medication management pathways for several years now. And it is also thanks to their support that we are here with you today to discuss this important topic. As you know, healthcare systems face growing pressure, and the digitalization of medication management pathways is an essential component to improve patient safety, reduce medication errors, enhance operational efficiency, and also support health and care professionals' well-being. This webinar will provide a little bit of an overview of funding mechanism at both the European level but also national level, and we will also showcase some good practices from member states, and specifically we will have the case of Ireland and the case of Italy. We have a very, very rich agenda today. I'm joined by several speakers. And so in order to not take away time from them, I would like to immediately welcome our first presenters, Dr. Daniele Bellavia. Daniele Bellavia is a research fellow in health economics and management at the School of Management and Engineering at Carlo Cattaneo Luick University in Italy. And Daniele will, with his presentation, respond or try to respond to the question, what are the investments that are required to digitalize medication management in Europe? And especially, are these investments profitable? So Daniele, I hand over to you, and the floor is yours.
Thank you very much, Federica. Let's go to the presentation. Okay. Federica already introduced me. I am Daniele Bellavia again, and I'm going to show you the main results of a study that me, together with my teamwork, published this year about the economic impact of automation in hospital pharmaceutical logistics and in the management of medication. First of all, a little bit of a context, for sure you already know, but literature says that in European hospital, up to 0.1% of all doses are affected by medication error. And also literature says that automation and digitalization can help to reduce this error by 50 up to 100%, so eliminate all these errors. Anyway, automation technology and digital technology are not still wide adopted in Europe because decision makers have to work with limited resources, and the initial cost of investment of this technology is a little bit high, actually, and this can be a little bit scaring. So our main objective, and I will say it later, is to create robust, large-scale economic evidence in order to help the decision makers to understand if these investments are profitable or not, and what is the time of the payback for these technologies. So again, let's say the objective. This study aimed to assess the economic and organizational impact of digital and automated technologies across Europe. So we wanted to make an assessment in 27 countries of the European Union, plus the UK. Now I'm going to show you the main results of the European Union countries, but in the article there is also the UK, of course. We wanted to assess the long-term sustainability of the investments. So we adopted a 10 years perspective, and we assessed 5 key technologies that, in our opinion, in our model, were representative of the process of transformation of automation and digital technologies. But of course, they're not all the possible automated and digital technologies, but they are quite well representative. I'm going to be very short, so I'm sorry, but time is limited. But here we have the 5 technologies, and they are the inventory robot. So it automates storage and retrieval in the central pharmacy. So it manages a lot of medications. Then we have the second technology, that is the unit dose system. Third, we have the automated dispensing cabinet, which is like the little cousin of the inventory robot, but it is to be installed in the wards. Then we have the smart infusion pumps with dose error reduction system to be assessed in the ICU setting. And finally, we have the oncology medication traceability platform to be assessed, of course, in oncology. Since, of course, oncology is a critical setting in hospital due to the critical chance of having inefficiencies and safety error. Now, just a little bit of methodology. We started with the assessment of standardized model hospital of 561 beds, which is representative of the average hospital in Europe, in the European Union countries. Of course, we used a lot of country-specific data, such as the labor cost, the cost of the drugs, and so on. Then we assessed 4 different cost drivers, which are the staff time saving, the drug wastage reduction, the optimization of the inventory level, and the possible reduction of medication error. Then we, starting from the standardized hospital, we scaled these results at the national level. And the final output of our job, of our study, was the production of a lot of numbers, of course, but in particular of 3 main financial indicators to be assessed on the long term, which are the return on investment, the net present value, and the payback time. For those who are not familiar with these 3 indicators, I'm going to show you very briefly. The first one is the return on investment, and probably it is like the most representative index, financial index, for the assessment of an investment on the long run. It is expressed as a percentage, and it basically indicates the profitability of an investment. The highest, the better. Then we have the net present value, which is like the cousin of the return on investment. The only difference is that it considers the inflation rate and the depreciation of money, since we are doing the assessment of a lot of investments on the long run. So in 10 years, we have to consider also this factor. And finally, we have the payback time that represents the time needed to recover the initial investment. And probably this is the most useful for the decision makers, since one of the main concerns for the decision makers, of course, is what is the time that I need to recover from this big investment? Of course, the shorter, the better. And we're going to see the main results now. As I said, we consider 4 cost drivers, and we valorized in economic way the reduction, the possible efficiency of these 4 drivers, starting, of course, from literature. Now, let's go straight to the results. We have this first chart where the red bars, the red columns, represent the initial investment to be done in the whole Europe, in the whole European countries, in 27 countries. And of course, the investment is to be done just once. And the green columns actually are the potential annual saving that you can have every year. So just once at a glance, you can see that the green columns are very high. And so in a short time, you can just reach the payback time. And we will see just in the next slide. The only possible technology that doesn't seem so convenient is the third one, is the automated dispensing cabinet. But again, we're going to see next that it is still convenient. And here we have the chart of the payback time. So the payback time here is very short. So it is between 2 and 7 years. 7 is the highest value, so it is the automated dispensing cabinet. And it means that, of course, you need a little bit longer time. But again, if we are assessing the investment in a 10 years horizon, it is still convenient. And of course, the payback time, the shorter payback time are represented by the inventory robot and the oncology traceability system. And there are two main reasons. The inventory robot manages a lot of packages. So everything that is through the central pharmacy is managed by the inventory robot. So you have a lot of volume of, medication that are managed. So with high volume, you can have higher saving. And then you have the most convenient technology in this perspective is the oncology traceability system, since the reduction of potential error and the reduction of wastage of expired drugs is particularly convenient because medication error and drugs, oncologic drugs, are very expensive. We have the return on investment. Again, the ROI is positive for all the five technologies. And again, in particular, the inventory robot and the oncology traceability system are the most convenient, but also the other technologies. And similarly, we have the net present value, which is again very convenient with the two technology that I mentioned before, but also for the unit dose system, automated dispensing cabinet, and the smart pumps. Now, it is interesting, in my opinion, to understand what is the savings breakdown, and it is quite interesting that the most important percentage of savings are represented by the reduction of medication error. So this is not just an economic saving and a more efficiency level. It is also the possibility to increase the safety level and the level of service that we give to the patient. And I don't want to annoy you with numbers, but I think that this table is quite representative of the study that we made. And I would like to focus just on the final row, on the final line. And we can see that in Europe, overall, we have a total investment of a little bit more than 3 billion euros. But thanks to this, we can have also a potential saving, a potential annual saving of 1,800 million. The return on investment in the 10 year is 167%, which is very high, almost like Bitcoin, but I'm joking, of course. The present value is very convenient, is almost 8 billion in the 10 years. And the average payback time for the favorite technologies in all Europe is 4.2 years. Now, is running out, so I'm going to be very short. Of course, we made a lot of modelistic assumption with a lot of limits and limitations, of course, but we made also a sensitivity analysis. And thanks to the sensitivity analysis, the results were proven robust and strong. So just one final message. The investment is indeed very high, but it is profitable. It is possible to return on the investment in a very short time. And most important, it is possible to give a better level of service and a better safety to the patients all over Europe. And that's all. And thank you very much.
Thank you very much, Daniele, for this extremely interesting and very valuable presentation. You've done an amazing work, so thank you so much for sharing these results with us. I know that we have MEP Tomislav Sokol with us. I'm not sure if he's able to mute himself and activate his camera. So I'm just giving him a couple of minutes. I know that he is moving from one appointment to the other, so I'm very thankful for him having made the time to be with us. So I'm not sure if MEP Sokol is able to connect. I see Eleonora, you're nodding, and I know you're in touch.
Yes, he's connecting right now in 1 minute.
Wonderful. So we'll just occupy the time for just the time for him to connect. And Daniele, sorry, I'm coming back to you at this point because you just presented. Um, I'm just curious. When I was seeing the number, when I'm reviewing the study, the numbers are exceptional, in fact, and I was wondering if, as you were conducting the analysis, you were in a sense surprised at all by the figures that you were seeing, or if in a sense already when you approached the study you were expecting this result.
Well, at the beginning, I was a little bit surprised, but actually, the first activity that we conducted was a review of the literature, and uh, just at the beginning, just viewing the numbers and the possible benefits and the possible optimization and the level of efficiency that was possible to reach, it was pretty clear that the valorization of those benefits would have been very convenient in economic way. So it was just a little bit of a surprise, but just at the beginning, and then of course it was pretty clear that the results would have been in this way.
Thank you very much, Daniela.
You're welcome.
Let's see if MEP Sokol managed to connect. I see he has.
Hello,
Oh,
I'm
there
here.
you are. Hello and
Yes, can you hear me
welcome.
and see me?
We can see you and hear you very well. Once again, MEP Sokol, thank you so much for making the time. We're very appreciative, first of all, for you to having agreed to co-host the webinar with us, and of course for your continued work that you do, of course, in the European Parliament, but specifically for the Critical Medicine Act and for the European Health Data Space. So MEP Sokol, I'll leave to you to give you some of your let's say words and setting up of the scene. We have heard the study that Dr. Bellavia has conducted, so the floor is yours.
Thank you very much. Thank you for making this initiative. Unfortunately, I will have to leave very soon, and I was not able to hear the previous speakers because of an enormous amount of overlapping events on healthcare in the European Parliament and around European Parliament today. But I'll try to say something about the European health data space and about critical medicine sector. I think these are the most important topic. As you know, EHDS is now in the phase of implementation. It took 1 year after the political agreement to come up with the final regulation, and now we have, let's say, 5 to 6 years of implementing the whole thing. So to prepare health systems, to digitalize them, prepare the personnel, the health workforce, to explain to the patients about what is at stake. Because if we don't do it right, such a profound change in how healthcare systems are organized would be extremely problematic. So if it is just implemented without any kind of preparation, explanation, both to healthcare professionals and to the patient on what it means, it would be a catastrophe because we would have enormous opposition to that. So I think when you speak about primary use, we have to prepare the healthcare professionals to know how to handle it, how to handle the electronic health records from the European level that will be harmonized. We also have to make sure that patients understand what their rights are. For instance, their right to limit access to a certain part of their data and all the benefits that it brings. Also to explain to them all the rights that they have in managing their own electronic health record, because in many member states this is something unheard of. So patients previously didn't really have a lot of control over their health data, but now they will have much bigger control than it was before, and they have to be prepared for that. The second thing, obviously, about secondary use of data, here we have to make sure to explain to people what are the benefits of that, what are the safeguards. So to make to explain that data that will be used, for instance, for research or policy purposes, will be anonymized or pseudonymized. That we have a lot of safeguards to make sure that this data is not misused. That we narrowly define purposes for which data can be used, so that we don't have a situation that big tech companies can misuse data for social media profiling or whatever. So we did whatever we can in the European Parliament to clarify the purposes for which data can be used for secondary use, also to clearly prescribe that only anonymous or pseudonymous data can be used, and of course also it's important to explain to the patients the importance of the opt-out mechanism, how it works in practice, so that we in the end get the data which is representative and not biased. So this is why we have time to prepare that. We'll need a strong health budget. Unfortunately, now we are in the process of negotiating the next 7-year budget of the EU, and the initial proposal is not very good for health. As you probably know, EU4Health program has been abolished. We now have a health under competitiveness fund and partly under resilience, but nothing is ring-fenced and nothing concrete about concrete numbers, and this is something that is unacceptable. Because if you don't have any protection of the ring-fencing of EU health budget, then this will be left to the discretion of some bureaucrat in the European Commission. This is not something that we want, so we'll definitely fight very strongly for ring fencing of at least part of the health budget, so that we know what we have at our disposal. And for EHDS, this will be essential. When we speak about to prepare the infrastructure, the knowledge, to train people, to create awareness among the general public, etc. When we speak about so that's about the CMA, the EHDS. When we speak about CMA has two main purposes. So one purpose is to strengthen strategic autonomy in Europe, to reduce our dependency on the others, and this is something which is extremely important, because you know that we are extremely dependent on imports of generic medicines from India and China. We see the pressure that American administration is putting on innovative companies to reinvest in the US, and if we don't do anything about that, in 10 or 15 years' time, we'll be as dependent on imports of innovatives from the US as we are now on dependent on imports of generics from India and China. So this is actually the question of the long-term survival of the EU. So if we are not able to protect our production of medicines in Europe, then in this kind of geopolitical battle that's going on now around the globe, we'll definitely be the big losers. And so this is the first objective of the CMA. The main tool to do that is public procurement. So creating this European preference, so that in public procurement, lowest price is not the only criteria, but that we use other criteria, and the main criteria I think should be production in Europe. So those companies who produce significant proportion of their product portfolio in Europe, let's say 50% of their active ingredients or final products, will be given preference in public tenders in the European Union. So by doing that, we are providing incentives and motivation to invest in Europe, and of course, I think for the long-term survival of European pharmaceutical production, this is crucial. We are also creating a category of strategic projects that will benefit from faster permitting, that will where health and security of supply will have preference over, for instance, environmental criteria. And I think this is something very important. The second purpose of the CMA is equality of access. We have two big instruments to achieve that. So equality of access, that all patients in Europe get the same medicines at approximately the same time, that they don't have first and second class citizens. The first tool is joint procurement. So joint procurement of several member states, which will create stronger bargaining position for them, but also make sure that all these member states get the medicines at the same time. Of course, we are also creating some important incentives for companies so that they can make long-term plans, like binding quantities that have to be part of the tender, so that they can plan several years in advance. And by doing that, we are providing also companies with incentives to engage in public procurement as well, joint procurement. And the second thing is mandatory distribution mechanism. You know that we have a situation that unfortunately national stockpiling in some member states contributes to having shortages in some smaller member states, and we want to prevent this from happening. This is why we want to have a coordination on the exchange of information on medical stockpiles and contingency stocks across the EU. And in case there is a shortage in one member state and the same medicines is on in contingency stock in another, that the mandatory decision can be made by the representatives of the member states that this medicine is reallocated to the country which has the shortage. By doing that, again, we are protecting patients from small member states, from member states who don't have such big stockpiles and contingency stocks, and make sure that we really have solidarity at work in the European Union, that we have coordination, and that all patients in the European Union can benefit from medicines at approximately the same time. So these are the most important things related to the CMA. Unfortunately, I have to go to another conference also related to healthcare, but I think these are the two most important things when we speak about EHDS and CMA. Digitalization is a major trend as well. I think EHDS will extremely contribute to that, and it's very important that we make sure that all providers are also prepared for that, but also with all the new things that will come with the CMA. So I have to apologize for having to run, but there are unfortunately so many things going on related to health at the moment in Brussels. So please excuse me, but I wish you a good webinar, a good conference, and I look forward to reading the conclusions as well. So thank you very much.
Thank you very much, MEP Sokol. Absolutely no need to apologize. We actually thank you very much for having made the time. We understand you have a very busy agenda, so we appreciate you squeezing us in. And we wish you a great continuation of your day. And of course, we will absolutely send you the conclusions.
Thank you. Bye-bye.
Bye-bye. And as we thank MEP Sokol once again for his presence, I would like to move on to our next speaker. I am very pleased to introduce Yacine Dif. He is a hospital pharmacist at the Geneva University Hospitals. He is also a PhD candidate in pharmaceutical sciences at the University of Geneva in Switzerland. His research focuses on drug shortages prediction and prevention, and he also leads a national research project that led to a smart dashboard that forecasts the shortages and suggests therapeutic alternatives. That is, and the focus of his study is what he's going to present for us today. So Yacine, I leave the floor to you and to your presentation.
Thank you very much. Welcome, everyone. I'm very happy to be here at this webinar. So I will present to you some of my work, what we are doing at the Hospital University of Geneva about the shortages. As you know, the shortages are increasing you can go on the next slide, please. Yes, the shortages are increasing in the last years. So we experienced between 2019 and 2023 at our hospital an increase of 50% from 377 shortage during 23 to 700 shortages in 23. And this is due to many factors, mainly COVID-19, geopolitical problems around the world, and we experienced that in our hospital. So we wanted to find a solution to tackle the shortages, and you see the numbers in 24 and 25. We could decrease the shortages. I will show you how. And we are now still at a high plateau. So we are plateauing at a high level of the shortages, but still we have now a view on what's going on in the hospital due to shortages, and we can predict and prevent them. Yeah, you can go to the next slide, please. So our main concept was to develop a dashboard, a smart dashboard, and the main idea was to connect clinical data to logistical data to predict drug shortages within the hospital. And yeah, you can go forward. Yeah, so the concept is to put together a lot of database where we have all the data of the hospital. So the first database you see in the top left, it's our ERP, so the Enterprise Resource Planning, where we have all the information, all the data about our drugs. We have more than 2,000 drugs in our list of drugs. So we take this database and we put it in a data lake, so another database where we have all the information about the drugs that we have in our hospital. The second database is the database of the ADC So this automated drug cabinet that we have in the wards, we have more than 100 now in our hospital. And these cabinets informed us about the stock level and the consumption of the drugs in the ward. So we have these two logistical database in the data lake. In the other side, we have all the prescription in real time, also put in the data lake. So with this three database, we have access to all the data concerning the consumption of the drug in our hospital, the prescription, and all this data are combined in a smart dashboard. This dashboard is ventilated through many criticality of the drugs, beginning from criticality 0, where we have all the antidotes, the antivenoms, so the very, very important drug that we could not afford not having them in our hospital. And we have criticity 1, where we have all the antibiotic IV, all the very important drugs, so clinically and logistically, so in the pediatric ward, in the ICU, emergency, etc. And then criticity 2 is all the drugs per us, so we taken by the mouth. So if we don't have them right now in the hospital, we can wait for 1 or 2 days, for example. All the vaccines are in this category. And we have criticity 3, where all the imported drug, because they have a special supply chain. If we import a drug from United States or from Japan, it takes 2 to 3 weeks. So we put them in this category. And we have a category where we consider this drug is less critic and less important, so less impact on the patient. And with this category, we have the focus on what is the more important shortage within our hospital. And we have also a view on our orders, the non-received orders, and a view also on the expiry date and a view on the ADC with many parameters. So the main alerts for the pharmacist are, do we have sufficient stock for the next 3 days of prescription? And do we have drugs with less than 2 weeks of stock? And if you just go one click further, I can show you an example. So if you take the Veklury, which is the remdesivir, an antiviral for the severe COVID patient who has to come to the hospital due to their COVID-19 infection, the system can show us how many prescriptions do we have in the hospital, within the hospital. So here we have 4 prescriptions, and these prescriptions are converted in milligram and boxes, prescribed boxes. So here the 4 prescriptions are represent 1,100 milligram prescribed, and it needs 11 boxes to fulfill this prescription. And if you have a green light, it shows us that the stock that we have in the pharmacy is sufficient to fulfill this prescription. So in one blick, I will show you also another example. You can check if you have a shortage within your hospital, and you have a prediction of 3 days regarding the prescription, and a prediction of 2 weeks regarding the consumption. So if you go one slide further, I will show you another example. If you take the posaconazole, which is an antifungic, you see 2 lines. The first line showing 12 prescription, a need of 4.6 boxes, and we have 0 at the pharmacy. And the orange light show us that there is a shortage, but we have an alternative. And the alternative is the second line from another brand, for example. And in this second line, you see we have still a problem because we have a red light, because we have a need of 4.6 boxes, and we have 4 at the pharmacy. And more than the stock of the pharmacy, stock level of the pharmacy, we have the stock level of the Pixie. So if you go on the right side of the image, you see how many boxes do we have in the Pixies. So in the first line, we have 0.8 box in the wards, and in the second line, we have 8.8 boxes. So in this case, when I work in the pharmacy and I see this problem coming from the dashboard, I check where are the prescription, because we can see where is this drug prescribed in the hospital, and we can see where are the boxes within the hospital. So we can make like a circular economy within the hospital and move the boxes from the ward to a ward to the patient that who has this prescription right now. And when we are on call on night, on the weekend, we are using this dashboard also to prevent the shortage in the hospital. And you see in the third line, so the IV solution of the posaconazole, you see a green light because we have now one prescription, a need of 3 boxes, and we have 85 boxes in the pharmacy. So these alerts helped us to to navigate through all the prescription of the hospital, and in one blick we can see all the problems regarding the shortages with these 5 alerts. Do we have sufficient stock for the next 3 days of prescription? Do we have drugs with less than 2 weeks of stock at the pharmacy? And we have an automatic alert showing us the non-received orders from the supplier more than 7 days, which in a lot of occasions showed a shortage coming because we're not receiving the goods. And we have also a view on the expiry date in the next 2 weeks, and we can check also the overconsumption. If you see the second line of the posaconazole, you see the arrow going up. It showed an overconsumption of the drug more than 50% in the last 14 days, and which also helped us to prevent a shortage within the hospital. So if you go now further, so we made a study and we checked during 3 months without the tool all some KPIs, so the number of shortage, the time spent on dealing with the shortages, etc. And we made another study during 3 months using the dashboard every day at the pharmacy. And the 2 main results, here I'm showing you the results. We experienced a decrease by 57% of the shortages within the hospital, and a decrease also by 25% in the time spent on the shortage per week. So we see a direct impact of this dashboard because through these 5 alerts that I showed you, we can prevent shortage and we can spare time. So if you can go further, please. So now as a perspective, you see on the left side, this tool now helped us in the internal drug shortages. We can see them coming. We have the time to speak with the expert to find an alternative, order the alternative, etc. And now we want to connect and to have more to connect with the outside, to the environment, and to have the information directly from the supplier. So we built a tool which is in the cloud, and we invited all our supplier to inform us about the shortages, when they begin, when they last, till when they last, and if they have alternative to present to us. And we are also working on a reliability index of our supplier. And I'm working also as the last part of my PhD on a drug shortage risk index. I will show you some the concept of this shortage risk index. So if you can go to the next slide. So how is this new platform built? So we have a platform in Switzerland named drugshortage.ch where the supplier can freely, so it's not an obligation, freely inform about the shortages. So we have access to this platform and it represents about 70 to 80% of all the shortages on the Swiss market. So we put it in this new platform and we work closely with 5 industries. You see the name here, Sondo, MEFA, Labatec, and V4. And they are feeding this platform directly with the information and updating the information about the shortages in this platform. We worked also closely with partners. All the hospitals now in the French region of Switzerland are partner in this project. And as soon as one of the hospitals has experienced a shortage, he can inform the other in this platform, and we are adding alternatives once a week to inform our colleague about the alternative that we found. And you see on the right side the power of the alternative. So if you find an alternative A is the first choice, it's a strict equivalent. You can use it eyes closed, let's say. And then second choice, you are changing, for example, the galenic form, you are changing the concentration. And C, you are changing completely the molecule. D, it's a non-strict equivalent. The prescription has to be changed by the physician. And if we didn't find any alternative, we named it E, so non-available equivalent. And in the study we made in 2023, we found that more than 15% of our shortages were without alternatives. So it means the prescription has to be changed, the physician has to change his protocol, and the patient is getting another medication. And why we did build this new platform? First, is to get the information directly from the industry. So we work with them as partners, and also to share, as I said, the expertise between us. As soon as one of the hospital pharmacists in the region find a solution, he share it with his colleague. So if you can go to the next slide. So the advantage for the hospital pharmacies is to have a shortage management tool, which is something new. We worked till now with Excel sheet, with Word, with Outlook, etc. Now we have really a new tool going in the direction of the digitalization. Sorry. We have also a centralization and the sharing information on shortages. As I said, it's a sharing of expertise between the hospital pharmacist. It's a time saving for the teams. We are now making a study about this new tool to see how many time can you save with this tool. And it's also helped us to have proactivity in the managing of drug shortages as we get the information directly from the industry. And also for the industry, it's also there are also advantages. It's a single point of contact with hospital, so they put the information in one platform and they informed all the hospital or the stakeholders with the information, and they can update it as soon as they have new information about when the goods and the drug are coming back. It's a smooth flow of information about the drug shortages. They can access the useful data. And also, we predict that it will be also time saving for the pharmaceutical industry. So we work with them really in a as transparent as possible. We share the information between us, and it's also, as I said, very there are very advantages for them. And just a word about the shortage risk index. So we make a proof of concept study to find what are the most impactful parameters to predict the shortages. So we find 5 parameters: the criticity of the drug, the supply reliability, the shortage in the last 18 months, the coverage weeks that we have at the pharmacy, and the type of alternative. Do we have A, strict alternative, or E, no alternative? And just to show you, I will not go into detail in the next slide, but how is this index constructed? So we work with a severity score combining criticity and the type of alternative, a probability score combining the supply reliability and the shortage in the last 18 months, which will bring us to an impact score. And the covered weeks, so the level of drugs that we have at the pharmacy are the mastering score. And then it will help us to prioritize in shortage handling by taking care more of the more impactful shortage, more critical one. And here you see how we will have a representation in our dashboard. So the next step in the dashboard to prioritize the risk, to prioritize the risk of the shortage and to work more on the red zone than in the green zone. And finally, so as a take-home message, we have a context now of difficult shortages. I didn't show the result, but we experience a longer duration of the shortages from 37 days to 49 days, so they're lasting more. Out of 2 shortages are critical, and 1 out of 5, as I said, with no alternative. And the profile of the drug shortage is also interesting. They are low cost, so more than 80% of the shortages, the box of the drug is less than 100 francs, Swiss francs. And under a hospital contract, 4 out of 10. As I present to you, it's an innovative solution combining logistical and clinical data to anticipate shortages with promising results. And the impact on shortage management is to improve by anticipation, improve our management by anticipation and proactivity. Thank you very much for your attention, and I hope you experience a new innovative tool to manage the shortages.
Thank you. Thank you very much, Yassine. Indeed, a very great and detailed presentation. I see that we have a question in the chat, which we will get to at the end of this session. I would like now to move on to our next speaker. She is Eleonora Vartumian. She's a policy manager at the European Health Management Association, and she will give us an overview of the national level capacity to provide data on hospital medication inventories. Eleonora, over to you.
Thank you, Federica. Welcome, everybody, to this webinar of strategic investments, leveraging EU funding for the future of hospitals' medication management pathways. This is a timely discussion, which is very intensely discussed right now, especially in Brussels, but also across Europe. And today we are bringing three important elements together: medication management, digitalization, and funding. I will start first by presenting the work of the EPACT Alliance, which is the Alliance for the Digitalization of Hospitals' Medication Management Pathways. Then I will describe about the current situation when it comes to hospitals, followed up with some EU initiatives, and concluding with the National Competent Authorities survey that we conducted with the European Medicines Agency. And that will be the overview of the presentation. When it comes to the EPACT, this is an initiative that started in 2022 by the European Health Management Association. We are very proud to lead this alliance, where we bring together multiple stakeholder collaboration to advocate for medication management and digitalization in current legislative policies, such as the Pharmaceutical Strategy for Europe, the Digital Strategy, the EU for Health Programme, and the European Health Data Space, with the main objective to improve patient safety, to reduce health professional harm and administrative burdens for professionals. As you can see here, we are very happy to have 22 Alliance members representing a wide range of stakeholders. Some of you, I saw you are connected today, so thank you so much for your hand-in-hand work we've been doing together. This alliance comprises of hospital pharmacies, patients, medical professionals, medtech companies, and pharmaceuticals, representing the entire spectrum when it comes to the ecosystem of medication management. Why are we talking about this topic now? We all know that the COVID-19 pandemic exposed the vulnerabilities when we have in the global supply chains and amplified the existing shortages, which have increased over the last 5 to 10 years across the EU. According to a study also of the European Association of Hospital Pharmacists, 95% of hospital pharmacies across 36 countries reported shortages in 2023. And of course, we all know that the most common medicines that we are facing shortages are the older off-patent generic medicines, which results into delays when it comes to care, cancellations, and sometimes even using riskier or more less effective alternatives. The problem that we are facing nowadays has to do mainly with how we manage shortages with using manual medication management. Previous speakers underlined some of the main causes that we have. The most difficulty that we are facing right now is that it's difficult to predict the potential shortages from manufacturers and wholesalers when it comes to supply chains. And of course, this has to do also when it comes to ordering, when it comes to stock takes, but also when there's a recall of a medicinal product, it's very hard to identify or investigate the drug batches on the hospital wards, which needs to be removed from the market. During shortages, of course, we also faced another problem during the COVID-19 pandemic. It was hard to identify the current stocks at the regional or national level, at the EU level, which required a lot of time and a lot of resources, especially when we look into alternative medicines. For all these reasons, it's very important that we look into how we can run efficient supply chain operations. We put in place an inventory management system. We raise awareness with the public and stakeholders involved in the medication management pathway, but also create a better communication when it comes to stakeholder collaboration as well of all the different entities involved. And why digitalization is needed, this has been elaborated very broadly previously, but the main goal is to have an inventory system that connects hospital wards and pharmacies, especially the community ones, so we can have the supply chains, we can do better procurement and anticipate spikes when it comes to demand and manage shortages in general better. The added value of manual and digital systems. Manual ones are prone to human error, especially nowadays that we have such a high number of patients and limited time for clinicians and healthcare professionals. It is unresponsive to demand changes when we have static ordering, whereas with digitalization, we can have data-driven and prediction systems. There's no real-time view unless the person goes and checks the medical cabinets, whereas with the digital ways, we can have predictive analytics and knowing the real-time inventory system. We can also not have forecasted system, whereas we also heard from examples where we create predictive analytics to forecast stockouts. This also helps to prevent stockouts, but also when it comes to expiry drug medicines, again, unless you are managing this, only with the digital system we can have with the FIFO management, first in, first out process, so we can make sure that we do not create medicinal waste. And last but not least, this way we optimize stock levels. And by integrating this digital system in a hospital setting, we avoid data silos in different hospital departments by connecting the pharmacy workers, the suppliers, and the electronic health records of the patients. There are a couple of policy initiatives. Some of them were mentioned by MEP Sokol, and some of them will be mentioned by Ole later on from the European Commission. The main ones that we are currently working on, this is a financial instrument, the Digital Europe program, which aims to improve when it comes to skills, infrastructures, business, and government. These run from 2021 to 2027. And these are the ambitious goals that Europe sets up to move into the digital age. European Health Data Space, I will not elaborate on this one as it was elaborately described by MEP Sokol. And here are the timelines that we mentioned when it comes to the introduction by member states. EHDS is already in force. It's up to the member states now to invest and put the infrastructure and skills necessary so we can meet the ambitious goals that we have stated with the data space. Another great initiative is the pharmaceutical strategy for Europe. The EPACT Alliance that I mentioned before has launched a position paper. I would highly encourage you to meet this. In this pharmaceutical strategy, we are addressing unmet needs, strengthening EU competitiveness, looking into preparedness and shortages, but also how to access innovative and affordable medicines, mainly for pediatrics and rare diseases. And last but not least, it was a Critical Medicines Act that was elaborated by MEP Sokol. EMA is a member of this alliance where we are working in two working groups, shaping the strategic report about how critical medicine should be used in the future and how member states can tackle this moving forward. And now we'll come to the study that we have conducted as part of EMA. We interviewed the European Medicines Agency, which is responsible for the supervision and safety of medicines, in collaboration with the national competent authorities. These are the ones who are responsible for the approval of medicines at each member state. We used a mixed combination study, conducting online survey with the EMA offices, but also structured interviews with 3 countries, Belgium, France, and Poland. We had 16 countries represented in the survey, so that was a good representation across the EU and broader European region. We ran the survey, as you can see, from May to July 2023, and we looked mainly how were the demand surges during COVID, if hospitals were ready to respond, and if there's capacity and real plan when it comes to hospital data collection for the future. And you can find the link here to read a bit more. So the first question that we asked the EMA offices were who were the key players when it comes to managing and preventing shortages with the medicine authorization holders, the companies who are responsible for this, together with the national competent authorities and hospitals being the primary contact points when it comes to shortages. And during the COVID, they have been regularly exchanging with when it comes to shortages at 83% of the respondents. I would like to highlight that we had around 195 respondents for this survey. 150 were mainly hospital pharmacists, and around 45, these were hospital managers. You can see a good range of representation across multiple countries. We had high level of responses when it comes to Belgium, Spain as well. We had and different countries represented in a more equal and balanced way. The question that we asked about hospital readiness was that during the pandemic, if they had an overview of planned stocks, so future stocks, with the respondents saying that 31% were somewhat unprepared. And when it comes to current available stocks, 31% said that they were somewhat prepared. When it comes to the EMA and how we are planning to identify critical medicines and report them in the European Shortages Monitoring Platform, the answer was that the EMA and the national competent authorities were planning to monitor sales data. I'd like to highlight that this is not a very accurate strategy to suggest, as we do not, this data is mainly managed by pharmaceutical companies, and it's very hard to know if the medicinal product is sold either in a hospital setting or in a community pharmacist. So we do need a digital system to monitor which medication goes where at which time with the expiry date, so we can have an accurate in-time visibility of the stocks. Another question about this was if they are currently sharing data with the national competent authorities. And surprisingly, we had some good answers. 47% of them are periodically discussing and reporting this to the competent authorities, and 23% no, or on an ad hoc basis. And when it comes to real-time and plan availability of stocks in hospitals, we can see that this is existing for some stores for medicine stores in the pharmacy world at around 51% only. The digital solutions, we also asked them what type of digital solutions you have in your hospitals. You can see that the IT systems connected to the central pharmacy is the most common one, followed by scanners and barcode systems and manual entry on computer words. Some of the other digital solutions were also mentioned by the previous speakers. And what concerned us a lot, it was about the time allocation when it comes to reporting the stocks and medicines, which was calculated around 1 to 4 minutes or over an hour for certain hospitals. And last but not least, when it comes to how they are planning to report hospitals about the visibility to the Medicines Agency starting in 2025, which is the mandate of the European Medicines Agency, we see that there is staff, we have no plans currently in place, which means we will not meet the ambitious goals set up in the policy initiatives, and that they need to invest in digital tools so we can meet up these regulatory demands moving forward. And I will close with a call to action. From what I presented today, we can see that we need legislative support to harmonize all the policy initiatives that I mentioned before. We need to incorporate digitalisation in the Critical Medicines Act about how we manage critical medicines. We need to allocate funding. Certain countries, by their own, they cannot tackle all these demands. We need to mobilize the funding at the national and at the European level so we can automate the capacity to manage and report stocks, and we can also ease the pressure from the workforce. And last but not least, we need national interoperable IT systems that automate information when it comes to the exchange of data from one supplier to another. As a final walkthrough and something that you might be interested to read for, as part of this EPACT Alliance, we have a lot of quality outcomes that you would like to read. The first one was what I presented today about national capacity to report inventories. The second and my most favorite is the How to Manager's Guidebook. This is a step-by-step guidebook if you are a hospital pharmacist or manager, how to begin this process in your own hospital or clinic. And the last one is the aim of today's webinar, which is launching a paper on strategic investments, the funding paper. I would highly encourage you to visit the EHMA website of the EPACT project, and then you can find all these resources, including more position papers as well on the pharma strategy and the European health data space and controlled substances management as well. Last but not least, as I'm also representing EHMA and I'm concluding with this project, with this presentation, I would like to invite you to the EHMA conference, which will take place from 10 to 12 of June in Barcelona. The call for abstracts is open. There's a QR code. We would be very happy to join us and present your research and all the findings that we are working on a daily basis. This is my email there. Thank you so much. I'm looking forward to the Q&A session.
Thank you. Thank you very much, Eleonora, for this great presentation. I also see a question in the chat, which, yes, we will be sending the presentations. We will make them available upon speakers, of course, consent. And of course, you can always go on our website and check out all the various resources that we have developed over the years. I would now like to move to our next speaker, Ole Norberg Jerestad. I hope I pronounced it fairly correctly. And he is policy officer at the European Commission, at DG Sante specifically. And his work at DG Sante is on the implementation of the European health data space. And before joining the Commission, Ole worked at digital health in Norway. Ole, I see you have already shared your screen, which means that you're all set to present.
Yes.
Wonderful. Yes.
Yes, as far as I know, yes. So thank you very much, and thank you so much for the invitation. So this will be not the first or the second, but the third mention today on the European health data space. But I hope I still will have something to add here. Just a bit on my background. So now I worked in DG Sante now for a few years, mostly or purely on the implementation of the European health data space, mostly on the primary use of health data. And I think there are quite a lot of details here in the European health data space that will be relevant from medication management perspective. So without further ado, I will, let's see, there. So it was already briefly mentioned by MEP Sokol, but there are a few different legs on the European health data space. So it's the primary use for basically for the use of data for delivery of healthcare. And the key here is that it's patients' access to health data. So that is sort of the tool that is used to legislate is that we are giving rights to citizens. But of course, as we will see later, this have quite huge implications on the need for streamlining, for standardization, for technical guidance on an extremely detailed level. So we will have a look at that later. Secondary use, this is use of health data for research or public interest purposes. So basically non-medical purposes, reuse of health data. And then the second tool we use in the primary area is that there will be requirements for EHR systems, electronic health record systems. There will be a CE marking. Basically, in order for you to sell your product on the market, you need to follow certain requirements. This is completely new at the EU level. Many member states have requirements on their EHR systems already today, but this is the first at the EU level. And of course, a lot of the purpose of this CE marking is to facilitate the flow of data. So the data should not be stored in just one system and almost impossible to move from one system to another. So it's interoperability, and that is the main purpose. Secondly, what I wanted to mention on the EHR system is that in EHDS, the definition of an EHR system differs slightly, or I will say probably significantly, from the industry definition of the word. So in EHDS, electronic health record systems is more or less all systems that process the priority data categories for the provision of healthcare. And I will show you later what those priority categories are, but they are rather broadly defined. And the consequence of this is that EHR systems in EHDS is quite a lot wider than what you would normally think of as a regular EHR system for basically for recording healthcare. Right. Okay. So the tools that we use, just to sum up, strengthening the patient's rights to their data. And the patients will have direct access to the data immediately after it has been transcoded. And it also builds on existing voluntary infrastructure called MyHealth.eu, which already today facilitates cross-border exchange of health data. So we have this voluntary system called MyHealth.eu for cross-border exchange that will be expanded now and be mandatory. I will not go through all the details of the benefits. I would just like to highlight one thing here. Here it is mentioned the European Electronic Health Record Exchange format. So this is one of the key enablers for this interoperability. So in order for these rights for natural persons, for patients to be executed, okay, you can go more or less wherever you want across Europe, and you should have, give or take, immediate access to all your electronic health data. How on earth will we make that happen? A lot of different systems need to be interoperable for that to happen, quite a lot of infrastructure. And one of the key components is this exchange format. So it will be standardized. It will be defined. What is medication? What is the key components? And what clinical terminology will be used? And that will be defined for cross-border use cases, for the rights of natural persons. I have the right to see my data in the format, and all patients have that right. And also EHR systems have an obligation to support this format. So this is really key, the exchange format. And of course, these three use cases that I just mentioned are in EHDS, but the implications might, of course, be quite a lot wider than these specific use cases. So we expect to see uptake of the format also beyond this. I mentioned the priority data categories. So electronic health data is, of course, quite vast. So a choice had to be made. What is the scope of the European health data space? And they came up with these 6 categories of health data. So it's the patient summaries. And a patient summary is it's a list of all essential information. So it's defined as 18 categories of health data, including current medications, previous medications, diagnosis, and quite a lot more, pregnancies, and so on. And also prescriptions and dispensations. So, of course, this will have to be defined in a structured manner. And they already have, but they will be mandated to be supported also in a structured manner. The second group, medical images, medical test results, and also discharge report. So, of course, there are other things than this going on at the hospital, but this is at least scope for now. And also just to mention a bit of the process. So as MEP Sokol mentioned, EHDS was adopted last year in March. What we are currently doing in the Commission and all across the member states is to define what does this really mean. So there are these rights. There is this thing called the European Electronic Exchange format. What is the format? What are these priority data categories? How are they defined? What are the elements that they comprise of? What clinical terminology should be used? Do we want to use SNOMED? Do we want to use ICT? Do we want to use a combination? Or what? And all these decisions are currently being made. So it's quite a lot going on right now. And the main vehicle that we use is a joint action project. A joint action project is basically that representatives from all member states are invited to participate in working groups. And this is what we are currently doing. And I think most of you have probably also been invited to, or hopefully invited to share feedback on this. All right. Access services rights, I think I've mentioned this. I also have a look at the time. So just to answer one question, where do the Commission get the nerve to think that they can make electronic data interoperable across all of Europe? At least in my member states, and I think probably many other member states, we are quite far away from it, from interoperable health systems. And I think one of the answers is that we already have this My Health at EU cross-border exchange. So 17 countries have already signed up and are exchanging, as we speak, health data. And this is sort of the main inspiration. This was the whole starting point. And here, to make this happen, a lot of infrastructure, a lot of technical specifications had to be made. And this is what we are using as a basis. Yeah. Secondary use. So we will say who has to make what data available to whom. And it will be a standardized application form, and hopefully, and also an infrastructure to actually share this data across from member states. So EHDS is not really solving. So the main purpose of EHDS is to solve a lot of the practical problems with access to health data. You still need an application, you still need to follow GDPR, but what we are solving is the infrastructure. So now you have a safe environment to analyze the data. You have a standardized template, and you can basically send one application and you can click on, okay, I want to send this to country A, B, C, and D, and then it's being dispersed. And the member states have also an obligation to set up an infrastructure to be able to receive all these applications. So in practice, it will be quite a lot easier to access health data, even though the requirements will stay relatively similar. Finally, I think this have been partially covered. EU for Health is the main instrument that we use in the Commission for implementing the EHDS. Of course, the bulk of the costs will be bared by the individual member states. So what we are able to finance at our level is cross-border infrastructures, and purely that, more or less. But there is quite a lot of also digitalization and handling of data at source. Most of the cases that will be dealt with outside of EU for Health. Thank you very much.
Thank you very much, Ole, for these insightful presentation. We also like to especially thank you because you have agreed to join us with a very short notice. So we really appreciate your presence here. And in this very moment, I would also like to move on to some very specific good practices and from member states. We have with us two representatives, one from Ireland and one from Italy. I would be pleased to start with Ireland first. And specifically, we have here Grant Carroll. He's Chief Pharmacist at the National Cancer Information System within the National Cancer Control Program in Ireland. And Grant, we would love to hear from you what Ireland has done in terms of the digitalization of medication management. So over to you.
Hey, thank you very much for having me and giving me the opportunity to talk to you about some of the work that we've been doing in Ireland around the digitalization of cancer services across the public healthcare network. So just to give you an idea of the Irish cancer, and this is within cancer services within the public healthcare system, there is 9 designated cancer centres across the island. 8 of those are adult, one of those is paediatric. And then we have 26 hospitals that administer systemic anti-cancer therapy. So they're kind of set up in a hub and spoke type model. So the cancer centers would do the more complex cases and a lot of the surgeries, and then the remaining sites would look after more simpler or satellite services. And patients would often move between these hospitals. Ireland is not particularly large geographically, so it's quite easy to move between a lot of these hospitals, and patients would often maybe have some cycles of treatment in the main hospital, and then they would move out to a spoke hospital later on. Population is relatively small, only about 5 million people across the Republic of Ireland. And as I said, patient care moves between sites. So historically, cancer care relied on fragmented paper records in Ireland up until very recently, and is still really probably quite in its digital infancy in terms of healthcare digitization. And it really led to limited visibility of patient history. So we had a lot of handwritten documentation, increasing the risk of information being really difficult to decipher, to try and understand where the patient had come from and where they were going. A lot of manual processes which slowed down care delivery. We used a lot of fax machines, a lot of phone calls to get information between hospitals and within hospitals as well. So yeah, really difficult across different hospital sites to move information around, and really difficult within hospitals as well. You know, we had separate pharmacy systems, paper prescription systems, which really led to inefficiencies in patient-centered care and timely care. So the shift we went through with the National Cancer Information System is to really transform how this care is delivered by providing a single national digital cancer record. The safety, care, and outcome of patients undergoing cancer treatment depends on timely decisions, as you know, and accurate data and seamless communication. So what we did with the NCIS or NCIS is changing how cancer care is delivered. And what it does is it provides one single national digital cancer record across all those 26 hospitals, currently live in 22 of them, but it will eventually be in all 26. And that really just allows accurate data, seamless communication between different hospitals. And really what our vision was, or is and continues to be, is a patient-centered longitudinal record. And I think what we mean by patient-centered and longitudinal is that record, every patient has one single cancer record. It doesn't matter where they are geographically. It doesn't matter what their diagnosis is. If they have multiple cancer diagnoses across their lifetime, all those will sit within that one single record. And there's no need to move. There's not even, it's a single database solution, so there's not even any need to move the information between different hospitals and different databases. It all sits within one system. And really, our ultimate goal then is ensuring that clinicians have the right information at the right time and in the right place. And using ANSYS, what we know is that every treatment is captured safely, accurately, in real time, and is accessible, and really no matter where the clinician or the patient is located. So geography stops mattering, really, in terms of information access. So as I said, that the National Cancer Information System supports the management of systemic anti-cancer therapy. It provides a longitudinal patient-centered care record, and records are accessible across all cancer centres and hospitals. And we have various elements within it. So the ANSYS supports, records, and manages critical clinical information. So it allows a lot of EHR type information, I suppose, in terms of clinical notes, assessment forms, things like that. Really, it comes into its real strength when we're starting to support systemic anti-cancer therapy. So multidisciplinary team meetings are supported within the system. And one of the really nice things about it is that what we would find across hospital groups in Ireland, and I'm sure this is quite common across Europe, is that we'll have patients from different hospitals. We'd have a specialist MDM in a cancer centre, and that patients from all the different hospitals around the country might be discussed at that MDM, but that can all be managed within the one system. So there's, again, no faxing of information, no phoning in, no sending paper forms. It's all completed within ANSYS. And then facilitating safe prescribing, preparation, administration of cancer medicines. So the National Cancer Information System is made up of 3 applications: C37 Cancer Centre, which manages the MDM meetings and some of the clinical documentation; BD Cato, which manages the safe prescribing, preparation, administration of cancer medications, so it's our medication management system. And then we have Extension in the background, which provides us a master patient index, which allows us to interface with all those 26 hospitals and create that single record. And really, again, what we're trying to do here is provide a single source of truth for clinicians, so they don't have to go looking different places, different notes to try and work out where the patient is in their treatment journey. And this is just really a sort of a visualization of a treatment journey within the National Cancer Information System. So you can see the treatment decision on the left there, made within the MDM system and C37 Cancer Centre. We then have an electronic medication order, pharmacy verification preparation, and then barcode medication administration. So we're really trying to close the loop on that patient journey with SACT treatment from beginning to end. It can all be digitized and managed electronically. And I think what we've tried to do along the way is that this just isn't an IT system. It's really a new way of working, and we've tried very hard to make sure that we consider the workflows of users and of doctors, of nurses, of pharmacists, of everybody who's using the system as we've put this together, as we've configured it, and as we've worked with our vendors to make it something that becomes a new workflow. As people move from a very different type of paper-based system, they're moving to an electronic system. And if the workflows don't work, and if the system isn't work for the users, then we won't have all those gains that you can get with IT systems. So every medication order becomes a record of cancer care. And you have alerts with annotations, audit tools, event logs. There's instant feedback to users to clinicians as they use the system. And that helps to support rapid response, continuous improvement, and they can make decisions about a patient's treatment based on information that is, again, in the right place and at the right time. And then one of the challenges of a system like this, with a single database across the entire public health system, 26 hospitals, as you can imagine, there is very often 26 ways of doing the same thing. And so what we've had to do with this system is underpin it with standardization. And again, that's required a massive rethink in workflows for a lot of hospitals. It's required a real buy-in from the clinical community to make this happen. So, for example, with cancer care, we have National Regimen Library, which is built by the single ANSYS national office, and that provides standardized order sets for treatment regimens across the whole system. As I say, it's a single source of truth. There's a centralized build and maintenance of a national drug file. Again, rather than all the hospitals having to do that themselves, that's one centralized drug file. And a lot of things like medication stabilities, concentrations, preferences for brands, that can all be managed in a central way rather than each hospital having to do it themselves. And we think that that hopes to streamline clinical workflows. So again, universal assessment forms and templates as well. Meaning that clinical workflows are easier to manage. And of course, improve communication then, because as we start to standardize a lot of that information, we can communicate that within our system between clinicians, but also potentially and hopefully outside of the system as well as we start to integrate externally. So just in some of the terms of the deliverables we have real-time information access. So wherever you are geographically, you can access information about the patient that you need to make a clinical decision. Collaborative care planning, so things like MDMs occurring across hospital groups, across different parts of the country, and that can all happen again seamlessly across the same platform. Operational efficiency gains in terms of information, again, just information being available at the place that needs to be, readable information, calculations, accurate calculations of doses and things like that, and enhanced data integrity and reporting, again, to do with thinking about workflows, making sure that the data that's being put into the system is part of the clinical workflow. If it works with the clinical workflow, that data becomes really useful. And then some of the patient safety, obviously patient safety and care quality advantages is we have a digital prescriptions that reduces errors, makes them readable. They have automated dose calculations. We're using those national standardized regimens, so standardized care across the hospitals and a safety verification process. And what we know now is that we've had over 500,000 medications have been administered based on digital prescriptions and NSIS. And we know that well over about 95% of those medications are based on a standardized order set. So what we are seeing is we're seeing the technology support the standardization of care across the country, which is really nice to see. And just have a couple of quotes here from people who are using the system. And one says that the true measure of the implementation was our ability to repatriate or move a patient from one hospital who's been unable to receive their treatment there as she was too unwell to travel. So the pharmacy and nursing staff saw firsthand how seamless a transfer of care was from one centre to another, and saw how NSIS facilitated the optimum and compassionate patient experience for a patient in question. Sometimes, as they say, seeing is believing, and I think this has demonstrated to staff how NSIS will improve the care we can deliver to our oncology patients. So just an example of something very simple of a patient who was in a satellite centre who couldn't go to Dublin, to the central centre to receive the treatment, but because of NSIS, that information was available and there was no need to muck around with moving paper records. And just a few more quotes from clinical teams in terms of the usefulness of the system. And really, I think just in terms of, we talked about strategy, Ireland has a digital strategy now. And what we can see in Ireland is that NSIS is laying the groundwork for that next generation of digital innovation for cancer care. So it is patient-centered, it's one single record, it's connected across the different hospitals, and it really is data-driven because we're looking at that standardization process as well. So thank you all for your time.
Thank you, Grant. Thank you so very much for this very clear example from Ireland. I see that we have a question for you in the chat, but because we are running a little bit out of time, I would ask you if it's possible for you to maybe respond to the question directly in the chat as I go to our next speaker, who is Alessandra Mecozzi from Italy. So she will be, of course, speaking about the Italian experience. And Alessandra is board of governors at SIFO, which is the Italian Society of Hospital Pharmacy. And Alessandra, over to you to tell us a little bit more about Italy and how we are doing in terms of the digitalization of medication management pathways.
Good afternoon to everyone. I bring the best regards of our president of Scientific Italian Pharmacist Hospitalier, Dr. Arturo Cavaliere. And now I could divide my, okay. And just a second, please. Do you see our slide?
Not yet.
Now?
They are loading now. They are loading now.
Okay.
Yeah, we see them perfectly.
Well, okay, I speak about Italy's approach to EU funding for hospital digitalization and innovative practices in drug management. In Italy, the investment for the ambitious plan, the Use Next Generation, is of 191 billion of euro. There is a strategic mission dedicated, the sixth, to the comprehensive health and social care reform, and about 20 billion of euro. This plan is very, very important for our nation because we have a demographic pressure. In Italy, there is an aging population with an elevated prevalence of chronic disease that is creating an elevated demand on healthcare service and resources. In Italy, the governance of health is regional, and we have a significant variation in healthcare quality from regional, and there is need to require target intervention. The mission 6 has been divided in two parts. The first part is proximate care and telemedicine. I would like to focalize my attention on telemedicine for better support of chronic patients, where the pharmacists of the health system have an important role. In fact, with telepharmacies and teleconsulting, a virtual consultation direct from pharmacist to patient place the patient at the core of care, offering accessible guidance and continuous support. The remote consulting pharmacists can help patients to understand their medication, to have a strong engagement in their therapy and overcome doubts or barriers. Finally, regular teleconsults enable pharmacists to monitor adherence, detect potential interaction, and optimize therapy effectiveness in real time, to have an effective pharmacologic therapy where the pharmacist is a bridge between hospital and community care. In this context, our society has developed a project, ongoing project on delivery. It was created to deliver hospital medication, especially oral oncologic drug, directly to patients' home. For older people, while enhancing both safety and effectiveness, integrating responsible management with digital tools and telemonitoring to support adherence. We have developed one platform managed by hospital pharmacists. This platform was a central repository and two apps. One app is for patients and allowing continuous management, telemonitoring, and of adherence, and tracking of adverse reaction. One is for delivery personnel, ensuring efficient logistic and management of therapy returns. The mission part 2 is dedicated to innovation, research, and digitalization of hospital. As I said before, we are three levels: national level digitalization, regional level digitalization, and hospital. My focus is a national level digitalization, where Italy has been taken several tools. With improvement in the use of monitoring registers of drugs. These registers allow to have equitable access to citizens, promote appropriate prescribing, and support regional planning and expenditure control. Another key milestone has been the full digitalization of the National Pharmacovigilance Network platform, improving safety monitoring and reporting. Finally, perhaps the most significant step is the electronic health record, and that is still going, is the nationwide expansion of electronic health record, a cornerstone for integrating patient data and supporting the continuity of care. So the electronic health record offers key benefits for both patients and healthcare professionals. It ensures continuity of care, standardizes data across regions, and empowering patients with access to their information. So, by providing accurate and up-to-date improves efficiency, safety, and therapeutic decision making. Now we are adopt in all regions, and this will adopt in all regions in the mid of 2026. About hospital level digitalization, also in Italy are improved automated drug warehouses plus RFID tracking. We are so many hospitals that have improved this system. For example, in the region where I work, Regione Lazio, Policlinico Gemelli and San Camillo have totally improved this system. This system is very important to improve traceability of drug and medical device for reduce error and the stock shortage. The PNRR is improving this system in a lot of hospitals in Italy with the funding of PNRR. There is a strong commitment at national level and at regional level to improve electronic medical record that allows real-time sharing of patients' data between hospital pharmacies and the clinical department for a coordinated care, accurate medication management, and enhanced patient safety. So this increasing digitalization facilitates mini HTA by enabling systematic data collection, supporting research, and allowing robust analysis of new therapies and medical devices for informed clinical decisions. How do hospital pharmacy add value? Surely the role of hospital pharmacists in the digitalization pathway is a strong collaboration with clinicians by utilization of electronic medical records to facilitate communication between hospital ward and the pharmacy, especially for antibiotic therapy with microbiology, for the great problem that all part of the world have about antibiotic resistance. Surely the part most improved is the management of oncological therapies. As CIFO, we have recently done a statement on management about oncologic therapy, from digital prescription until administration to the bed of patients. This digital prescription in Italy is in most hospital pharmacies and assure accurate communication and reduce effective risk management across the entire cancer treatment pathway. Another important tool can be the pharmacist in the patient's discharge management, ensuring the better appropriation and optimization of discharge prescription to promote continuity of care between the hospital and the community, aligned with the prescription. About logistic, we said before all people before me. Another part that I would like speak is about in the mission 6 part 2 is training, scientific research and technological transfer. As a scientific society, we have a strong commitment to produce courses to develop technical, digital, professional, and managerial skill among our professionals. In this transformation. So we can say that now we are here as hospital pharmacists. We have skill for clinical management, for a collaboration interprofessional, for optimization and safety and patient education. There are robust data and evidence on impact of hospital pharmacists in reduction and adverse drug events, and in team with all health professionals that have care of patients in reduction in readmission and reduction of medication discrepancy. We are sure that the implementation of digitalization can improve this data for a better healthcare system. So in conclusion, we can say we are in historic transformation and represent a very opportunity for our health system to modernize and the entire healthcare system for future generation. And our society and the pharmacists can be a catalyst in delivering safer, more efficient, and patient-centered pharmaceutical care. This strategic investment can expand role of all health professionals, also pharmacists, and creates benefits for patients, healthcare providers, and sustainability of the entire system. Together, we can build a resilient, innovative, and sustainable healthcare future for Italy with hospital pharmacists, and we, as a society of pharmacists hospital, are here. Thank you for your attention.
Well, thank you so much, Alessandra, for this, again, a very insightful presentation from Italy. We are a little bit over time, and I see that several people are either returning back to work or needing to leave. So I would really like to take the opportunity to thank all the speakers that participated today. You have received several compliments in the chat for how informative your presentation were, and overall the interest in the topic covered by this webinar, which means that, of course, we need to do more, and we will absolutely do more as EHMA on this topic. I remind all of you that we have a lot of resources on the EHMA website, which is www.ehma.org. You can discover more about the topic covered today and a lot of other resources that we have produced on the digitalization of medication management pathways. I would like to once again thank Becton Dickinson BD for the support to the work that we're doing on this topic, and I'm left but wishing you a wonderful continuation of your day, and thank you again for joining us today for this webinar. Have a great day and goodbye.